Hello, my name is Laura Taraboanta, and I will be a freshman at Case Western Reserve University in the fall, and I am part of the Office of Civic Education Science Internship Program. And I worked alongside Dr. Charles Maudlin on the positive predictive rate of ultrasound for vascular-related complications in the immediate renal transplant post-operative period. Kidney transplantation is one of the most common transplant operations in the United States, and it is most often due to end-stage kidney disease that is primarily caused by diabetes and high blood pressure. More than 2 out of every 1,000 are afflicted by either end-stage kidney disease or chronic kidney disease. Common symptoms triggered by ESRD are headache, weight loss, loss of appetite, nausea, urine production decreases. However, most patients experience no symptoms, thus being unable to detect the disease in a timely manner. This is a picture of a kidney transplant with forked arteries. A few facts about kidney transplants are that one donated kidney is needed to replace the work previously done by your kidneys. The donated kidney may be from living-related donor, related to the recipient, such as a parent, sibling, or child, living unrelated donor, such as a friend or spouse, or deceased donor, a person who has recently died and who has no known chronic kidney disease. The following is a diagram of a pediatric cadaveric end block implantation, and you can see the donor aorta and donor vena cava connected to the main aorta. This is a pediatric allograft. As you can see, it is quite small. And this is a regular allograft. My research focused on the renal duplex ultrasound that is said to not only be a useful tool in early evaluation of possible graft insufficiency, but also a reliable, non-invasive, and readily available tool to assess the effectiveness of the transplant. An ultrasound such as this would show the vascular complications in an allograft after post-operative period. In the immediate post-transplant period, kidney transplant surgeon utilized the duplex ultrasound as a mechanism to evaluate the integrity of blood flow in the transplanted renal artery and vein to determine whether or not any significant peri-transplant fluid connections might exist, and to evaluate the blood flow patterns within the transplanted kidney. There have been a few cases where the reported findings on the postoperative renal transplant duplex have suggested the presence of a vascular occlusion in the patient with postoperative anuria or gluria, where clinical decisions were made based upon the findings of the duplex ultrasound to subject the patients to re-exploration or interventional radiological procedures, which necessitate the use of nephrotoxic contrast in post-renal transplant. In some of these situations, re-exploration revealed normal blood flow without vascular compromise, despite the fact that the duplex ultrasound finding suggested vascular occlusion or flow compromise. In the first 24 hours after surgery, the graft must be explored due to protocol or clinical indication, and it is a physician's responsibility to act if the results are abnormal. Thus, it is vital that the duplex ultrasound is checked for accuracy in order for the physician to be able to properly confirm the diagnostic without further exposing the patient to unnecessary risks and trauma. This project focuses on a few main points. However, due to time constraints, we mainly focused on specific aim number 6, to determine, among other things, whether findings of immediate post-renal duplex ultrasound, stratified by the source of the allograft, deceased versus living, is a predictor of the incidence of delayed graft function. For this study, we reviewed the epic charts of all kidney transplant patients, excluding kidney pancreas, from the years 2005 through 2011, looking over their operative reports, ultrasound readings, and discharge notes, to analyze which of these patients underwent either post-renal transplant duplex ultrasonography, transplant angiography or magnetic resonance angiography, along with surgical re-exploration based on the findings. The following was a sample of the data collection. We looked over the resistive index, renal velocities, delayed graft function, and whether or not the donor kidney had multiple arteries. With our statistical analysis, we discovered that abnormal ultrasounds were associated with 24% delayed graft function versus normal with 14% delayed graft function. After adjustments for donor age and donor type, abnormal ultrasounds were associated with a 2.7 odds ratio for DGF, although the p-value for ultrasounds was not statistically significant as it was under 0.5. Out of the 100 patients we focused on from the year 2008, only 3 went back for re-exploration, with 1 having a false positive reading by the ultrasound. Further review of the patients from the years 2005 through 2007 and 2009 through 2011 must be completed in order to conclude the accuracy of the renal duplex ultrasound with statistical significance using varying outcome measures to find a correlation between the ultrasound. Furthermore, comparison between the ultrasound, angiogram, and MRA based on variables such as access to testing, any preliminary preparations, risks, level of trauma to the body, and costs must be investigated in order to decide whether or not to amend clinical guidelines. The significance of this retrospective chart review will help the renal transplant team develop clinical guidelines to indicate when patients, either living or deceased donor recipients, should undergo post-renal transplant duplex ultrasonography rather than having every patient routinely undergo such testing, thereby reducing the incidence of false positive renal duplex and avoiding further trauma to the patient. We also began looking over the medical reimbursement of the renal transplant ultrasound for the purpose of reducing any unnecessary costs. Finally, I would like to thank my team of mentors, Dr. Charles Modlin, Dr. Myra Feldman, and Dr. Jesse Schold, for taking time out of their busy schedules to help me out with my research, and to the Office of Civic Education, Nedra Starling, Rosalind Strickland, Abraham Al Hardy, and Kelly Krause for making this all possible for us. Thank you.